Hi, and welcome to the LIT Review series. I'm Chris DiRienzo, a fellow in neonatal perinatal medicine at Duke Hospital, and today we'll be spending the next few minutes talking about necrotizing enterocolitis. Of note, my research is supported in part by the Thrasher Research Fund, and we're looking at the association of NEC with feeding and blood transfusions with grant funding from 2011 to 2013. Over the next 10 minutes or so, we'll hit the following 4 bullet points and give you a high-level review of necrotizing enterocolitis, from understanding its pathophysiology up through how to recognize patients with NEC and then begin appropriate management. So for starters, what is NEC? Well, as the name implies, necrotizing enterocolitis is a significant injury to the bowel, and that ranges from inflammation all the way to the picture you see stage left, which is truly necrotic intestine. Why NEC happens, we actually still don't know. It's been described as an aberrant response of an immature gut, and has been associated with a number of different types of things, including, most specifically, prematurity and feeding. Of note, we have found recently that human milk is protective, and it's one of the few things in neonatology we've had that can actually reduce incidence of NEC. This image from a 2011 New England Journal review gives one of the more recently described proposed mechanisms for NEC's pathophysiology. As you can see, it involves a number of different pathways and truly is a multi-hit hypothesis for why babies get NEC. The research is ongoing every day around the pathophysiology of NEC, and within the next 10 years, we expect our understanding to continue to greatly improve. So who gets NEC? Well, by and large, this is a disease of premature infants. The peak incidence is around 24 weekers, and it is very rare in term babies. There are basically 2 kinds of NEC, medical and surgical, and it's important to note that surgical NEC is much more serious and carries a much higher mortality and morbidity rate. So classically, a baby who looks like he has NEC will be a premature infant, usually around 2 weeks old. He'll be feeding. They develop some feeding intolerance, which can be gastric residuals, vomiting, diarrhea, or an increased abdominal girth. Sometimes they'll have bloody stool, but not always. Sometimes these babies will look sick in that their blood pressures will drop, they'll have vital signs changes, poor perfusion, and sometimes they may not. And so your initial workup often includes a laboratory evaluation. You'll get your blood counts and cultures. You'll look at some electrolytes, and you can see the sorts of laboratory derangements that we've noted here. Interestingly, though some of these are sensitive for NEC, they're not at all specific. And so once you've begun your laboratory workup, radiographs are really your next step, and that's how we can stage NEC. The first 3 stages have been described by Bell. This was decades ago. Stage 1, suspected NEC, which is really no radiographic signs, but the sort of clinical signs that we've talked about previously. And then medical NEC and surgical NEC. So medical NEC is characterized by a pneumatosis and or portal venous gas. And surgical NEC is characterized on an abdominal x-ray by free air or pneumoperitoneum. And to give you a sense as to what those look like, we'll look at some radiographs next. These 2 images are courtesy of the Children's Hospital Los Angeles, and on the right you can see what pneumatosis looks like, the sort of mottled lucencies all throughout this baby's intestines, and especially the sort of tire-like appearance near that replogal tube just to the right of it. That's very characteristic of a cross-sectional pneumototic bowel. Now to the left you can see one potential appearance of free air on KUB. Of note, usually we'll get an AP and a cross table, which will help see free air layer, and if necessary you can always do a left lateral decubitus film as well. So that brings us to management. Babies with medical NEC are generally managed symptomatically. We stop feeding them. You can correct any fluid or electrolyte issues that have arisen. These babies are routinely treated with antibiotic courses, beginning with a rule-out course and potentially extending that to a 7, 10, or even beyond day course, depending on the baby's symptoms. Routinely, we'll do radiographs every 6 to 8 hours at first, monitoring the progression of pneumatosis and or portal venous gas. And generally, these babies wait a long time before beginning to feed again, up to a week and potentially longer. Management of surgical neck is actually still controversial. Generally, the two modes of management are either surgical drain placement at the bedside or an exploratory laparotomy that generally involves some sort of bowel resection and primary anastomosis or ostomies and mucus fistulas. There have been a couple of studies that found no difference in outcomes and no difference in survival, though interestingly, one study showed some potential for long-term neurodevelopmental improvement with an XLAP. This is why there's a study in the U.S. right now called the NEST trial, which is underway. It's about half enrolled at the time of this LIT, that's trying to determine whether one of these two management strategies will be best. And so finally, that brings us to a more high-level management of neck within a unit. And so the three things that NICUs around the world have really come up with to help reduce overall neck rates have been, first and foremost, human milk, and then using antimicrobials in a thoughtful but certainly still aggressive manner, and then finally thoughtful use of antacid therapy, as these are the sorts of things that we've found associations with in the past. Once again, it's important to emphasize we still don't fully understand the pathophysiology and are continuing every day to work to better understand how we can reduce rates of neck across the United States and around the world. And finally, let's hit on outcomes. And so neck is a very costly disease. Just the burden of neck itself, not even including long-term care, is over $1 billion in the United States annually. Overall mortality is around 20 or 30%, but that's much higher for surgical neck. And these babies stay in the hospital longer. Survivors are at risk of not just neurodevelopmental impairment, but a number of other significant comorbidities. So this truly is a severe disease of prematurity. So in summary, I hope we've been able to give you some high-level points about neck. You should be able to recognize neck both on your exams and in your clinical practice and have some thoughts about how to begin the workup and management, as well as to reduce the overall incidence of neck in your unit over time. Thank you again for listening to this LIT on necrotizing enterocolitis. I've included some key references from the talk, as well as a note that the Faneroff and Martin book, Neonatal Perinatal Medicine, is a very good resource to look to first. It's chapter 47, and there's about 10 pages that present a very good review, both of the known pathophysiology as well as ways to manage neck, and I would highly recommend it. Thank you very much.